Well, thank you guys so much. You're really just too kind with the introduction. But if there is any cloning technology you know about, please please let me know. That would be very helpful. It's nice to see um, some faces I recognize and a lot of new ones. But I'm really pleased to be able to have the invitation and do this talk and do this deep dive into EoE medical therapy. So this is the disclosure slide. Uh, and then, so the objectives um, are that David provided really to describe the main therapies available for the treatment of EoE and their mechanisms of action, understand when, how, and why they're selected. Is there a way that we can personalize for patients? And then understand the treatment goals and get a sense of how the therapies compare. I guess, David, I'll ask you to maybe keep an eye on the chat if someone does have a question. Um, and obviously we'll all talk in the Q&A as well. But you know, I'm okay if there's something that's confusing, just you can stop me and we can talk about it a little bit. But this is the outline for the talk. I'm going to start with just a general overview of EoE treatments and therapeutic goals, and then we'll really move into this deep dive of the discussion of some specific treatments. I know you've already heard a little bit about the newer AGA Joint Task Force guidelines, but I'll mention a few of them where they come. And really with this focus on proton pump inhibitors, the traditional topical steroids, which are kind of the homemade version, and then the esophageal specific topical steroids, and then finish up with the emerging biologics. And through this, I'm going to try at the very end to give you this overall treatment algorithm and some ideas about where things might go for personalized treatments. And throughout, I'll try to highlight clinical and research advances for you. So just as a refresher, I know that this was way back last week, but I wanted to just remind everybody where we are with EoE diagnosis, which is you have this clinical presentation. Adolescents and adults, typically dysphagia predominant, sometimes heartburn and chest pain. Kids, anywhere from growth troubles to failure to thrive to abdominal pain, vomiting, nausea, heartburn, etc. You end up with an endoscopy and a biopsy. You've heard about, I think, the endoscopic findings. If you have the EOs at 15 eosinophils per high power field, or about 60 EOs per millimeter squared if you're using density, that makes the diagnosis very likely, but then you have to take this step of evaluating for non-EoE disorders that cause or potentially contribute to esophageal eosinophilia, making sure you work this differential diagnosis before you end up definitively diagnosing EoE. So with that standpoint, once you have the diagnosis, where do we go? And one thing I'll say as we talk about this, the key thing about these guidelines, which were from the AGREE conference in 2018, is they took the PPIs out of the diagnostic realm and they put it and they were put as a therapeutic option. So before, this last step here was a PPI trial. And you couldn't, if you didn't respond to PPIs, then you had EoE. If you did respond, you had something else maybe. That looks like it's not true. And so we'll talk about PPIs as a treatment option, not in the diagnostic pathway here. So this is a list of the treatments that you heard about kind of in the management lecture. Non-pharmacologic with the diet elimination and esophageal dilation. And then where we're going to focus here is on the proton pumps, the steroids, and the biologics. Still in the US, on my side of the border here, no approved medicines from the FDA still. And as you know, you have the one topical steroid in both Europe and Canada right now with the Jorveza. So when we think about treatment, before we get into the nitty gritty, what are we actually trying to do with treatment? Well, you might argue we're trying to do all of this. We're trying to improve symptoms, how the patients feel basically, but also trying to improve biopsies, the endoscopic appearance, patient's quality of life, theoretically, either treating or preventing complications like stricturing, food impaction, nutrition issues. You might try to improve esophageal distensibility, how soft or rigid the esophagus is, which can drive symptoms and complications. Maybe you want to improve biomarkers or genetics or molecular features. And then I would say you may want to prevent progression of the disease if you can start treatment early enough as well. And one thing about EoE is that I think many people agree that in most cases, not all, but in many, EoE progresses from an inflammatory condition more to a fibrotic or scarring condition. And so, if you start with the normal esophagus, you initially have, especially in childhood, this inflammatory type picture, lots of eosinophils, lots of edema, lots of other inflammatory cells. Over time, that triggers a fibrotic process where you start getting scarring in the esophagus. And ultimately, you end up with a longer duration of disease that's undiagnosed or untreated, a scarred, ringed, narrowed esophagus. And so as you have this progression here, you get more fibrosis generally in adults than children. You need more dilation generally in adults than children. And the medical and dietary aspects really treat the inflammatory part of the condition, where we would have to rely on dilation right now to treat the fibrostenosis. And a good chunk of this proof of principle data is certainly from Katya and Elaine and the Swiss group, looking at their natural history information. So then when we treat patients, well, how do we know they're better? What kind of outcomes are we looking for? So the first thing is, can the patients tell us they're better? And yes, they can tell us that they feel better theoretically. But when we think about outcomes, and I'm sure Katya went over this in detail, the symptoms don't always correlate with other disease outcome metrics. And so in my own practice, and when I'm talking with patients and other providers, I try to say that you have to understand that the symptoms and the histology may not track together. And symptoms alone, in my mind at least, it's not enough just to monitor the symptoms. How does this happen? Well, you can have a situation where you get rid of the inflammation, the biopsies get better, but the symptoms persist. How can that happen? Well, one is if you have a stricture and the stricture persists and you have a narrow caliber esophagus that continues to drive dysphagia symptoms, but the biopsies are better, but the fibrosis remains. Or you can be on a treatment and you can have an infection, a viral infection or a candidal or fungal infection that continues to give symptoms in the esophagus, even though the eosinophils are better. And then on the other hand, you might have the symptoms improve, but inflammation persists. And this can happen if patients modify their diet, if they're more careful with what they're eating, if they avoid foods that stick, if they eat soft foods. Or if I do a procedure and I dilate a patient, they'll tell me their symptoms get better, but their biopsies may still be very inflamed. And so you have this discordance, and you can't just think about one single outcome when you're trying to gauge success. And you'll see that in a lot of the data from the trials that I'll show you. So I like to think about this spectrum of response from non-response to complete response along histology, symptoms, and endoscopy. And there's a fair amount of controversy about like what kind of values you might put in each of these boxes. But you can argue that you have a completely normal biopsy, a completely improvement in symptoms, and a completely normal appearing esophagus. Everybody could agree that's a completely normal, great result. And you can also have, on the other hand, non-response where nothing is getting better. But you can have a lot of things in the middle, and you can also have different things in different categories. So like I said, you could have a normal biopsy and ongoing symptoms, or normal symptoms, but still very severe endoscopy and only a partial response in histology. And so I think this kind of a chart can be helpful to think about all the different combinations of outcomes. A recent paper with Iko Hirano and Glenn Ferruta, they tried to do this in a more friendly consumer reports kind of nomenclature here, where you have the same thing, symptoms, histology, and endoscopy on this scale from good to bad. And you can decide where a patient might stand. A patient in the middle is good on all of these. This patient is showing that the symptoms persist, and the endoscopic activity persists, but the histology is better. Whereas this person is having worsening histology, but better symptoms in endoscopy. So there's a number of ways you can kind of visualize how to think about response, but generally we're thinking about symptoms, histology, and endoscopy. Now, the other thing before we get into the nitty gritty about the treatments is what are some barriers to the treatments, and how might uh, patients encounter problems. One is, of course, at least in the US, probably less with you guys, is cost. And that's at a personal cost, not cost to the system. So without a drug covered in the US, most insurances won't cover it. And so you fight with the insurances for approval, but in the end, it ends up being very expensive. And that can certainly be a huge barrier. Another barrier is whether the patients can actually adapt these asthma medications to take them themselves. And we'll go through how that works, and it can be very confusing for patients. And similarly, adherence can be a problem. Twice a day medications on for a long time that they have to mix themselves or adapt themselves gets to be draining, and they may not adhere. There's a concern about side effects and long-term safety. And I think many people have sort of this steroid phobia and worry about the effects of steroids, but we don't have much data on many of the treatment modalities long-term, especially when we think about long-term durability. And then, again, trying to think about symptom outcomes versus biologic outcomes is a barrier, because if a patient feels well, they may not come back. They may stop taking their medicine, and then they may have trouble down the road. And then some patients have a strong preference for a non-pharmacologic approach. They view medications as a band-aid covering up the problem, and they want to target dietary elimination or find out what their allergy triggers are. So lots of things to consider when you talk about the treatments. And then as we move into talking about the detailed treatments, just a reminder that there's both the guidelines here and the technical review that inform the guidelines, published in Gastro and Annals of Allergy, Asthma, and Immunology last year in the fall. So you can find a lot of the data that I'll talk about in these articles. So we're going to start with PPIs. And as I kind of mentioned when we're talking about the diagnostic pathway, the prior guidelines for EoE required this PPI trial to confirm EoE diagnosis and distinguish it from GERD. And there was this concept, mostly based on how EoE was initially described, which was in children who appeared to have bad reflux but didn't respond to any reflux treatments, including PPIs. And then when you put them on a diet therapy or steroids, they got better. So there was this sense that if you responded to a PPI, you did not have EoE. And if you didn't respond, you did have EoE. So that's why this PPI trial came about, usually using double dose or high dose PPIs, twice the approved doses. And with this, what we noticed is that we saw high response rates to PPI use in patients who seemed like they had EoE. These are younger patients, all the typical symptoms and endoscopic features that you've heard about in the last sessions, but who got totally better with PPIs. They felt better, esophagus looked better, biopsies were better. And then as people delve into this more, you could tell that the clinical and endoscopic and histologic and immunologic molecular features, all aspects of the disease, before you took the PPIs were really not very different, or not different at all, between the people who did and did not respond to PPIs. And so based on this, there was this evolving thought that actually PPIs were probably treating the condition rather than distinguishing who had EoE and who had GERD. And even more interestingly, there were some mechanisms of why PPIs would work in EoE. We usually think of them, rightly so, as anti-acid medicines. They're acid suppressants. But it turns out they have a lot of other features as well, some of which are anti-inflammatory. And so they suppress one of the chemicals, it's called eotaxin 3, that is an allergy factor that brings eosinophils into the esophagus. The PPIs suppress this independent of their acid effect. They also help to tighten up the esophageal barrier function and make the barrier less permeable to food allergy antigens. So there's good evidence of why PPIs would work. And they work well. This is some of the data from the guideline article, where they recommend use of PPIs over no treatments. Now, what this is, these data are a forest plot. And if you haven't seen this before, these are all of the different individual studies here that have looked at PPI use in patients with suspected EoE. And then this is the estimate here, from 0 to here 80% for the patients not achieving histologic remission. So it's kind of upside down. This is the non-response rate. And this is the summary value here. So the non-response rate is about 53%. So 47% of people respond to PPIs on the histology standpoint. That's pretty good. The medicines are inexpensive, they're safe, and they're pretty effective. So this is where the use of PPIs comes from. Now we'll talk about topical steroids. So the history of this, and I'll go through it a little bit, is that early on, patients were trying to, you could give prednisone, a systemic steroid in EoE, and it would work. But of course, people were very concerned about systemic side effects. And so what researchers tried to do was to develop a topical way to coat the esophagus, similarly to as you might put, hydrocortisone on a rash or a bug bite on your skin. And so what they ended up doing, first off, was taking a puffer of fluticasone, puffing it into someone's mouth during a breath hold and swallowing. And that would seem to work. And then secondarily, later on, they took budesonide in the Respule formulation that would go into a nebulizer machine and mixed it into a syrup and swallowed it and coated the esophagus. Also seemed to work. But these are sort of do it yourself and do it at home kind of methods. So what did this look like data-wise? Well, this is the first report from 1998, pediatric case series, fluticasone and beclomethasone inhalers. All 4 of the patients responded. They felt better and their biopsies got better. And since that time, many studies, observational, prospective, retrospective trials really confirm the effect. And so this is a meta-analysis of both observational and randomized control trials of fluticasone and budesonide. And you can see overall, this is histologic response, 68% for fluticasone, about 77% for budesonide, but generally pretty consistent responses here in these different studies. And this spans pediatrics and adults. And these medicines, despite you making them up at home, taking the budesonide Respule and mixing it with whatever you had around, trying to puff the fluticasone in your mouth. I don't know if you've ever tried it. It's actually quite challenging to do this. And it seems to work very well. And based on this and other data, and this is a meta-analysis in the guidelines of the randomized trials up through 2016 17 at that point. Again, they're seeing here a 61% histologic response rate pooled. So very nice efficacy overall. Now, having said that, there's a lot of problems with these medicines. Okay, so just as a few examples, you prescribe someone fluticasone, they get it from a pharmacy. The pharmacist assumes they're getting it for asthma. They get a spacer. Even if they use the medicine correctly by trying to swallow it, the medicine in the spacer, it won't go into the esophagus because it gets stuck there because you're not breathing it in. And I have a laundry list of ways that people have messed up their topical steroid preparations when they're trying to do it themselves at home. I've had someone spray fluticasone on their hand and lick their hand, like no idea what that is. I've had someone use the fluticasone nasal spray and swallow it. Theoretically, that would work, but you need 37 squeezes of that to get to the appropriate dose for regular fluticasone. I've had primary doctors take a look and see they're on a fluticasone inhaler 220 micrograms and say, well, your asthma isn't that severe. And they come back on a 44 microgram inhaler. I've had people given the enteral release formulation of budesonide, not the Respule formulation of budesonide, and they wonder why they're not feeling better. So on and on. It's a major problem when people try to, make it themselves at home. Plus, you just have no idea what they're getting. Because this has been an issue, lots of people have tried to do other stuff. So this is a study out of Boston Children's where they were looking to mix viscous budesonide either with Splenda, which is sort of the first thing that was described because it was sweet and sticky and little kids like to drink it, with an elemental formula, powder formula. And it turned out that elemental formula powder worked very well, maybe even a little bit better than mixing the budesonide with Splenda. And this made the parents feel better because this was felt to be more natural and not some kind of chemical like Splenda that who knows what that does to your body when you take a tablespoon of it twice a day for 10 years. So that's one thing people have looked at. Actually, I think in Switzerland, they do this a lot. And also in Northwestern, Hirano does this a lot. You take the fluticasone discus. Why would you use this? This is a device designed to get the med into the lungs, not into the GI tract, which from an asthma standpoint is the problem with the inhalers. Well, if you pop the discus open, you have a blister pack here of fluticasone powder that you could open up and put on the tongue and swallow it all. And it's quite effective delivery mechanism. And this is just a retrospective study. You can see the eosinophil count goes down, some decrease in endoscopic severity, some decrease in an unvalidated symptom score. So this is something that people try as well. For me, I use a lot of compounded medications because I have a good relationship with a compounding pharmacy here. And she developed a custom budesonide and fluticasone compounded syrup. And so these are some papers written by a fellow and a resident here where we're looking at this. And, like other steroids, most had good improvement in symptoms. These are often refractory patients who came to me trying different formulations, and I put them on these compounded formulations. And even in that setting, a third or more of patients are responding to these. So this is, another option that I use. And so I think there's lots of different things people are doing without an approved kind of medication. The other natural question that comes up is, you hear about budesonide, you hear about fluticasone. Is one better than the other? And so I was lucky enough to be able to do a trial, a comparative efficacy trial of these formulations, looking at the budesonide homemade syrup versus a fluticasone inhaler. And generally they work quite similarly. So these are the main outcomes of this randomized trial. It was a double dummy trial, which was kind of cool in that we gave every patient a syrup and every patient an inhaler, and they took both, but only one of them was active. And so that way they were still totally blinded, I was still totally blinded, and all the outcomes were objective. And that's a nice way to do it when you're looking at two different formulations. So this top panel here is the eosinophil count. And you can see huge reductions in the eosinophil count before and after treatment with both medicines, and no difference post-treatment with the medicines. This is the dysphagia symptom questionnaire score, a validated symptom metric. Same thing, nice reductions in symptoms with each treatment, no difference between the meds. This is the endoscopic outcomes. Again, perhaps a slightly better decrease with budesonide than fluticasone, but still quite similar. And then these are the response rates by histologic cut point. So very similar to the meta-analysis, 70-ish+% for budesonide and over 60% for fluticasone. So very consistent actually with the meta-analyses. And so for me, this was reassuring in that, okay, whatever the patient's comfortable with, whichever one you can get paid for, it's still okay for them to use. It was also good for drug development because both kinds of formulas can continue going forward in development for patients. Now, more recently, there's been some study of mometasone, another steroid used in asthma inhalers for EoE. And just like the other ones, this is another study out of Boston Children's. They actually were using a compounded version of the mometasone as well, dosed by height. The esophagus gets longer as kids get bigger. And you could see a general good response rate similar to where the budesonide and fluticasone is, about 3/4 responded. And if you looked at both the steroid failures before and the steroid naive patients, both did pretty well with this medication. It seemed pretty safe. So retrospective study, small, but yet another steroid that could be used. So as I've been talking about this, I kind of have been intimating about the importance of the steroid formulation. And this was another study that I was fortunate enough to do, where we actually were looking at two different formulations of budesonide. We're looking at the viscous formulation with the solution that you swallow, and a nebulized formulation where you take the budesonide and you swallow the inhaler. And the reason that I picked this one, it was done in a randomized trial by Dr. Straumann in Switzerland, where it was quite effective. And so what we did was we compared one to the other with the patients, but we also tagged the medication and watched where it went in their esophagus to see how well the formulation stuck into the esophagus. It was nuclear tracing. So we essentially did esophageal emptying study. And what you can see here is this is with the budesonide. And so this is like a movie compressed into one image, where a patient would swallow the medication. It was tagged as a bright color on the nuclear scan. And then you could watch it start in the mouth and go down the esophagus into the stomach. So this is two illustrative patients. And the medicine does what you want, right? It's going in the esophagus and all of the medicine is ending in the stomach. Compare that to this non-esophageal formulation where you're trying to swallow this nebulized vapor. So you're getting the stuff blowing all over the room first. So the radiation safety people weren't so happy with me. But then you're like, where is the esophagus? Okay, so all the medicine for this person is going into the lungs. This person, he's got a huge Adam's apple. And then, and he does have two lungs, but you can see like a strand of the esophagus. And most of the medicine is not getting in the stomach. It's going somewhere else. And so this shows that it does matter what kind of formulation you have. And if we correlated the biopsy results, the improvement in the biopsy, with the amount of the medication that ended up in the esophagus, there was a very significant correlation. So people who looked like this were non-responders, and people who looked like this were responders. And I think this helped to move the concept that the formulation is pretty appropriate. So that brings us now to these more custom esophageal specific formulations that are under development. And in the US, what's under furthest along is this budesonide oral suspension. It's essentially a pre-mixed standardized formulation of budesonide that's formulated to be mucoadherent and stick to the esophagus. And these are the data from the phase 2 study of this. And again, I'm going to show you the symptoms, the histology, and the endoscopy. This is the symptom outcome showing the improvement or change in the DSQ score. Green is placebo, blue is active. More improvement in symptoms in the active compared to placebo. This is the histology, better histology outcomes, better remission, less than 6 EOs per high power field compared to placebo. And this is the endoscopic EREF severity, how bad the esophagus looks, much more improvement in the active treatment compared to the placebo arm. So based on this medicine went forward to a phase 3 study, and these are the initial top line data that have been released. This is a much larger study. It was more than 300 patients, active and placebo. Same thing, very nice histologic response, significantly compared to placebo where there was almost nobody. And now we're looking at the DSQ here, but not the change in the score, but the number who had a 30% improvement or better. And this was more significant in the budesonide compared to the placebo. But you can still see there was a pretty big placebo symptom effect here, which you need to take into account when you design clinical trials. So this more data hopefully will be released from this study, and this is moving along as publicly announced last month into FDA review here. So we'll see how that goes. These are the data for the budesonide oral dispersible tablet. Very, very nice. I'm going to let Chris talk about this next. This is just sort of to whet your appetite at sort of their response rates in their phase 3 trial for their primary outcome here. But that's all I'll say about that. You can stay on the edge of your seat. In the US, as opposed to a budesonide dissolvable tablet, well, not just the US, but there's a fluticasone dissolvable tablet under development as well. These are phase 2B dose finding data that were presented, I don't know, about a year and a half ago now, where they were looking at, compared to placebo here, 4 different doses of fluticasone, 1.5 milligrams QHS at bedtime, 3 milligrams at bedtime, and then split dosing, 1.5 milligrams twice a day, 3 milligrams twice a day. Now, to compare these doses, when we usually talk about the fluticasone puffer or the discus, we're talking somewhere around 1,750 to 2,000 micrograms, so up to 2 milligrams a day. Here you're looking at 6 milligrams a day as the top dose. Why is that? Fluticasone is not absorbed through the GI tract really. And so there was not felt to be a safety issue related to absorption. And so they wanted to look for dose effect. And you can see for histologic response here, there's a reasonable dose effect that maybe plateaus around 3 milligrams a day or something, but certainly better than the 1.5 micrograms. So that's the histology. These are the endoscopic findings. Again, EREF scores here all improved compared to placebo. And again, same theme, histology, endoscopy, and symptoms. This is actually looking at the ESI that I'm sure Katya reviewed with you on the last thing. Again, numerically better improvements compared to placebo, and according to some of the doses, hitting statistical significance as well. So this is now in a phase 3 international multi-center study as well. So we'll see how this looks. Now, all of these studies that I've just shown you are for very short treatment courses, anywhere from 6 weeks to 12 weeks, basically, initial treatment essentially for EoE. What we know about EoE is that it's chronic and that most people will need ongoing treatment. There's very clear data now that if you stop the medication, the disease is going to recur, and it's going to recur quickly. So these are data from that budesonide versus fluticasone study that I showed you. In that study, for the proportion, the 2/3, 3/4 of patients who responded after, that was a 2-month study, after they had a histologic response, we stopped the medications and just watched them for up to a year to see what happened. We allowed esophageal dilation during the study, but when they had symptoms recurrence, we did an endoscopy on them. And so overall, what you can see here is this basically ongoing, substantial, sort of relentless recurrence of symptoms in almost everybody. The median here was about 8 months, and I think that's because about half of the patients got a dilation. In the patients who actually had symptoms, they recurred pretty quickly, within 3 or 4 months. No difference in recurrence between budesonide, and as you might expect, if you have dilation, you had a symptom response that's a bit longer than if you didn't have dilation. But very nice data, I think, that if you stop the treatment, the symptoms come back. When we scope these patients, the vast majority of them had histologic recurrence as well. I think even better data, again, I think Chris is going to review this with you in just a couple of minutes. This is from the randomized withdrawal study. And so again, just to uh, be a little appetizer for you, very compelling in terms of what happens when you take away the medications from responders. So it's clear basically you need maintenance therapy. And even before those data came out from the budesonide dissolvable tablet in these guidelines, basically continuation of topical steroids is recommended over discontinuation of treatment. Um, we can talk in the question and answer about, is everybody need this? But in my practice, yes, I talk about maintenance therapy for essentially for everybody. Okay, so that's sort of the topical steroids. And let's change gears now to the biologics. And to kind of understand what the biologics are doing, they're really targeting what we know about the EoE pathogenesis. And so this is a cartoon of where we think EoE pathogenesis is. And at a broad overview level, you have some kind of allergen that impacts the esophageal barrier, the esophageal lining, which probably it has some defect in it. And that combination leads to this allergic response, which what we call this Th2 cascade, this allergic inflammatory cytokines. And as you go down as you go down this cascade, you'll see these cytokines, which I'll point out, but they lead to eosinophils and mast cells infiltrating the esophagus, remodeling, inflammation, decreased barrier function, and then all of the clinical symptoms we know. And the reason that I put this up is really at every one of these arrows now, in almost every one of these cells, there are candidates as biologic medications that can target these pathways and potentially be treatments for EoE. So this is not even a complete list. It's a reasonable list, and I'm going to talk about these set of anti-cytokine and receptor mediated kind of treatments. But in addition to these, you can see there are some treatments under development that may target TSLP. This is kind of like a master allergy regulator. IL-15, which is another allergy cytokine, and even alpha-4 beta-7 integrin, which is a protein on inflammatory cells that it's almost like an address finder that allows those cells to localize a place of inflammation and get out of blood vessels into the tissue. But I am going to talk really about these IL-4, IL-5, IL-13, and then the Siglec-8 receptor as key inflammatory mediators in this pathway. So IL-5, this is a key eosinophil, basically trophic factor, you could think of it. It's a cytokine that promotes eosinophil growth, maturation, differentiation, and activation. And there's very strong experimental evidence that if you block this, you don't get EoE. And so there's been several randomized trials now quite a long time ago, 10 years basically for all of these, showing some proof of concept. And this graph has just the eosinophil count here. And you can see compared to before treatment, after treatment in the small adult study and in these larger, including this very large study in kids, you see this very good decrease in the eosinophil count. Now, is it all the way to zero? No, but there's a pretty moderate effect here. Why weren't these medicines carried forward at the time? Well, even though you had this histologic effect, when they were looking at symptoms in these patients, everybody improved, both placebo group and active therapy. And that was because at this time, most likely, we didn't have any validated metrics. We didn't do all the hard work that Katya told you about to understand what the symptoms were. They were multi-symptom questionnaires. And because of that, these didn't go forward at that time. But there is a trial that I'm helping with, basically investigator initiated, looking at mepolizumab, which is an anti-IL-5. And the other reason to know about these is that both mepolizumab and reslizumab are approved for eosinophilic asthma. And so in a patient who has eosinophilic asthma, who needs one of these, who might also have EoE, they might get a benefit from it. So anti-IL-13. IL-13 is another Th2 cytokine. It's critical to EoE pathogenesis. It triggers the esophageal epithelium to make that eotaxin 3 chemical that brings the eosinophils into the esophagus. It's responsible for a host of gene changes in the epithelium that really prompts EoE. And so that's the rationale for this, RPC4046, which is an antibody against IL-13. These are data from the phase 2 study, 99 patients. Randomized to either high dose here, medium dose, or low dose, high dose, low dose, or placebo. And this study was quite promising. This is the change in the eosinophil count, no change with placebo, and big time changes with the medication, both dose levels. This is the number of patients who got under either 6 or 15 eosinophils, very similar, 50% to, say, the budesonide suspension data that I showed you. This is the change in symptoms. This is using what they're calling a dysphagia symptom diary, which is looking at, again, dysphagia severity and frequency. And you can see a strong trend in the high dose group for improvement. This study was only powered for the eosinophils, not for the symptoms, but they were looking at symptoms too. And then here's the EREFs. Again, a little change in placebo, big time changes with the higher dose group. This actually was interesting in that they looked separately in a pre-specified analysis about steroid non-responders, and these non-responders had a very similar response, good response, as the overall group did. And then this is the only biologic with long-term data published so far. You could see maintenance of response up to 52 weeks and generally well tolerated. So hopefully at some point soon, this will start phase 3 investigation. IL-4, this is another inflammatory allergic cytokine. And so this medicine, dupilumab, blocks the IL-4 receptor. So it decreases both the IL-4 and the IL-13 pathway because the IL-4 and the IL-13 receptor have to associate to work. Dupilumab is already approved for asthma, eczema, and chronic nasal polyps. And so this was a proof of concept study, phase 2, to see if it works in EoE. And same kind of theme. Their primary outcome was actually symptoms. So they were looking at a different symptom metric, the Straumann Dysphagia Index, which is dysphagia severity and frequency over, Katya will have to tell me, 7 days, I think. Yeah. And so you see much improvement in symptoms, significant compared to placebo. Placebo's in pink here. This is the change in eosinophil count. You see an increase in placebo, big decrease, 90-ish% with the medication. And here you're looking at an 82+% resolution, histologic response at less than 15. Here's the EREFs, much improved. And this is the first study that's published data on looking at the esophageal stiffness. And the esophageal diameter actually increased a couple of millimeters with this medication compared to placebo. So based on these data, this has gone into phase 3, and this was some top-line data just released a few months ago from the first part of their phase 3 program. And you can see the histologic response in the active group compared to placebo, looking about 60–70% response rate compared to almost nothing in placebo. And you see a significant decrease in symptoms. Now they're using the DSQ for their symptom outcome. So again, very promising results. And this phase 3 study is ongoing, waiting for long-term follow-up data as well. Pretty favorable safety profile. And a lot of experience in asthma, eczema, and other conditions. So again, if a patient has severe eczema, severe asthma, and EoE, this medicine may be a benefit to those EoE patients. Here's the IL-5 again. This medicine, benralizumab, is different than the others because it blocks the IL-5 receptor. When it does this, it actually causes eosinophils to be depleted. And so in relatively short order, you lose all the eosinophils in your body. And this medicine is approved for eosinophilic asthma and recently studied in hypereosinophilic syndrome in this New England Journal article. And of the 20 patients in the study, 7 had eosinophilic gastroenteritis, basically. And if you focus on just the red box initially, you can see that they had high eosinophil counts in their stomach and duodenum, some in their colon and ileum. And after treatment, they were all 0. So strong information that this antibody depletes tissue eosinophilia. And so this is now in a phase 3 study for EoE that is currently active and enrolling around the world. And then the last biologic I think to talk about is this anti-Siglic 8. Siglic 8 is an interesting receptor that's very specific to eosinophils and mast cells. And this antibody, when it activates that receptor, it also causes depletion of eosinophils and deactivation of mast cells. And so this was a phase 2 study. The medicine's called AK002, or it's now called larentilimab. And it's studied in eosinophilic gastritis and duodenitis. And just to show you that in the different doses, you saw a huge reduction here in the eosinophil counts compared to placebo. You saw big time decreases by about half or more in the symptom score. And this responder analysis is improvement in symptoms and histology, much higher than placebo. Basically, nobody in placebo was getting better. The interesting thing about this is about 14 patients in this study had esophageal involvement, so essentially EoE, and most of them got better too with their tissue eosinophilia and their symptoms. So this med is now in a phase 3 for eosinophilic gastritis and or duodenitis, and in a phase 2/3 for EoE. So there's a lot of drug development on the biologic front for these medicines. And so where do we stand? So, you know, you've got these are this is reasonably up to date by Thomas Gruder about all of these different potential treatments that are in the pipeline. You know, the budesonide suspension is in phase 3, finishing up in the US. The budesonide dissolvable tablet is done and approved. Here's the fluticasone dissolvable tablet, you know, in phase 3. And then these are all the different biologics that are in various forms of development, but the benralizumab, the anti-IL-13, the anti-IL-4R, and the anti-Siglic 8, just to mention a few. There are some small molecules that are under initial development as well, but it was a little too much to try to pull some of those into this talk tube. We could talk about them in the question and answer if you'd like. So I know that's like a ton of information and an overview of where all the EoE treatments are, but I think let me try to pull it together for you with this algorithm. So you start here after the diagnosis, say, and the first thing is the initial treatments. For me, if there's a stricture, I'm going to come up here and I'm going to dilate first off. But from the pharmacologic standpoint and other treatments, you're going to have a choice of 3 first-line treatments, either PPIs, topical steroids, or dietary elimination. We don't really have comparative efficacy trials or data yet for these. So it's really up to the doctors and the patients using a shared decision-making framework on what they want to do. I think in the setting where there aren't any approved medications yet, like in the US, I am still going to PPIs pretty frequently up front because they are inexpensive and many people have a nice response. But you know, there's way more randomized trial data for topical steroids, and when they're approved, you know, you have an approved option that may be what people choose, or if patients want to do diet elimination, they can. If you have an adequate response, you go ahead and you continue the treatment and you monitor them. If you don't have a good response, you switch between these first line therapies. So you didn't respond to PPI, you go to steroids. You didn't respond to diet, you go to steroids, or vice versa. And then if you don't have a very good response after all of that, that's really where you're going to be coming in, I think, initially to biologics in these clinical trials here. But their place in the algorithm really hasn't been set up yet. How might you distinguish between all of these treatments going forward? Well, I think that hopefully we're going to have some way to predict whether people can respond to treatments, and you might actually assess their phenotype. Are they stricturing? Are they not? Are they allergic? Are they not? Are they early childhood? Are they older kids? Are they adults? And then with that, you might be able to more rationally allocate these different treatments. So let me show you just briefly what we know about some of this personalization. So we know about a couple of steroid non-responsive phenotypes. One is what we'd call this extremely narrow caliber esophagus. This is basically like having a straw for an esophagus, okay? So look at, this is like, you know, 3 or 4 millimeters, tiny, tiny esophagus, right? Just so small. About 9 or 10% of patients with EoE have this. These patients have a much longer disease duration. So these are people who've been untreated for a long time. They stricture down and get smaller. They obviously need much more esophageal dilation, and they're less treatment responsive. So if you look at these odds ratios of treatment response, they're less than a third as likely to respond as to people who don't have this super narrow caliber esophagus. So this is a group of patients, you might say there's not a lot of them, but you might say, what's the point in using a steroid? Maybe you want to use something else, or maybe you have to use high dose steroid or esophageal specific steroid or something like that. So this is sort of a one way to look at it. Um, I'll skip that. There are also some data in these different studies that look at other clinical predictors. So in this study by Fuad Mowat, older age and dilation made response less likely to topical steroids. In this study by Asher Wolf, dilation made patients less likely to respond to steroids. And then this study by Swathi Alori, who's one of our faculty here, there were 5 factors: younger age, no food allergies, um, needing a dilation, having edema in the esophagus, and having a hiatal hernia. These were associated with non-response. So again, you might be able to predict some steroid non-response in certain situations. There's some thought that genetic predictors might work, and this is a randomized trial of fluticasone and by Mark Rothenberg's group. And he was able to find a few genes here that had a different pattern in responders of expression than in non-responders. But this hasn't really been borne out. There's been 2 studies that are looking at this, with this one again by Swathi being the largest, that didn't corroborate those initial gene predictors. So right now we don't have any genetic predictors that we know about yet, although there are some very interesting candidates. And then most recently in this study by the Seeger group, they were looking at cytokine expression and saw 5 different categories of patients related to cytokine expression that may go into how you would um, prescribe a biologic. And so, you could look here, you have this IL-5 line. Some people have very little IL-5, some people have a ton. Some people have very little IL-13 and some people have a ton. And they could find these different categories, like category 5 had high IL-5, low IL-13, and they tended to be much more inflammatory. So you might say, okay, maybe that's a person that gets an IL-5 directed medication. And like this group 3, their IL-5 pretty low, but IL-13 much higher. And so, okay, maybe that's an IL-4 or IL-13 kind of group. Or this group has a ton of mast cells. Maybe they should get a Siglic 8 thing and deactivate the mast cells. So this is very, I think, interesting and suggestive in terms of where we might be going. But of course, we need a lot of work to get there before we can personalize this so well. So in summary, the PPIs and topical steroids are really the mainstay of the pharmacologic treatments. Both are effective. We need comparative efficacy data for sure, but the therapies are really changing rapidly. And just the number of trials of novel agents now compared to 2 years ago is amazing. We have the esophageal targeted steroids, we've got these emerging biologic agents, and we have to work out where all of these are going to go in the treatment algorithm. And the goal is ultimately to get to personalized medicine, but we're not really there yet. And I think one of the fun things about the field is it's so multidisciplinary that it's fun to work with all of the colleagues. And but it also is, I think, why we're seeing such rapid advances, because we're pulling together a lot of people with different expertise. Um, and then last of all, I just point out, David would be say that I'm remiss if I didn't include this, but I did check out this website, EGID Partners. It's a patient based network that is looking to develop this ongoing patient cohort so they can help us do patient-centric research going forward. So thank you again for the ability to talk today and the invitation. And